Welcome to Chapter 3 for Exercise Program for Special Populations. We're going over musculoskeletal conditions and disorders. All right, so starting with disorders of the spine associated musculature. These have varied causes, symptoms, and are difficult to define. Treatment with exercise will usually be individualized for the unique symptoms, and included are low back pain and postural disorders. So again, back pain is the number one reported pain that most people have. And the causes a lot of time, there's a lot of general similar common causes, but at the same time, like in our society, for the most part, is under, like overstressed muscles in the sense that, people are overweight. They don't strengthen the muscles enough. They get overworked when they have to stand or sit in certain positions too long, and things about that. Those are kind of like a big general thing that sort of happens, but even within those, there's a lot of differences that happen as well. And again, you've got folks that have had trauma by trying to lift too heavy at some point, either, in the gym or at work. You have somebody that's been in a car accident, sports injuries, and a lot of times those things will linger. Sometimes they can be things that just cause issues all the time. You may have, what they'll, again, somebody has a slipped disc, so to speak. Well, there's all kinds of things that are actually like more technical that can fall under what a slipped disc is, right? And so again, it's kind of hard to really understand all the things that, if you have a client that has back issues, especially when, they in turn don't really understand sometimes what it is. Like one day the pain just showed up, or they're, again, this is one of the things I get onto, like I get a little irritated with, uh, and again, it goes two parts. It's irritation with doctors for not being specific in their diagnosis. Sometimes, again, sometimes they talk down, like, and I've had doctors like that. They talk down to you because they think you're not going to understand. And they'll be like, oh yeah, you got a bad back. Well, what's a bad back? you know, that's pretty, yeah, explain to me why my back in particular is bad, right? And you got on the other hand, you got some doctors are really good about describing that. But then again, you've got folks that, just plead ignorance, and they'll go the other way where they try to explain to them what's going on, what's causing it. And then you got the person who just really doesn't either want to understand or try to understand. They're just waiting for the doctor to be like, get to the, like, here's how we're going to fix it. And they're like, oh yeah, but I'm gonna give you some, some muscle relaxers or pain meds or whatever, or we're gonna have surgery, or yeah, I need you to start exercising. They send you to come see somebody like me, and you come to me and you're like, oh yeah, doc said I had a bad back, after they actually did describe everything to you, but you didn't take it on yourself, right? And so we have all these issues when it comes to that. But again, with that, you got to figure out what the root cause is. If you can figure out what the problem is, what's going on with those things, and then for each person, we've got to figure out the different treatments that we're going to use. And again, us as exercise specialists, we're not going to necessarily be doing treatments. What we're going to do is kind of like, we will be an added on feature to whatever things that they're doing, right? So we may help with a little strengthening and stretching, and some other things that we may be able to do for them, as long as it's okayed by their doctor and their rehab specialist if they have one, right? So again, like I said, low back pain defined as pain and discomfort localized below the costal margin and above the inferior gluteal folds, with or without leg pain. If the cause is unknown, low back pain is referred to as a non-specific low back pain. It's characterized by duration. So acute, something that's been there less than 6 weeks. Subacute, 6 to 12 weeks. Chronic has been there basically over, like 3 months and over, right? So again, and there's a lot, like it says, there's a lot of things that can cause it. And sometimes people aren't really sure, it just shows up. And without really good investigation, a lot of times you don't know what it is, right? In developed countries, it occurs 58% to 70% of individuals, increasing with age, right? So again, it's very, very common. Like I said, number one most described pain. Um, Results in substantial costs, medical office visits, medications, surgeries, diagnostic tests, like if you're going into different rehab stuff, you're going back through different, like there's all kinds of things that, like maybe you're trying to use, like, but you buy like commercial or not commercial, but like some type of medical grade back brace while you work. And, maybe you decide you're going to try to put some type of orthotics in your shoes to see if that helps, or you buy a little pad to stand on where you work. You try maybe getting a more ergonomic chair, so on and so, all that stuff can lead to some heavy costs, right? So again, onset of low back pain can come from a lot of different causes. Physical attributes such as age, weight, height, fitness level, etc., can be really big attributing factors. Occupational hazards such as high physical demands, heavy lifting, and whole body vibration. So you think of stuff like working a jackhammer, or like if you sit in a tractor all day, and you're doing stuff like that. Yeah, those can all add to it. Body structures affected include invertebral joints or discs surrounding musculature or components of the neural system, increase in symptom variability. And again, LBP or low back pain is one of those catch-all terms for a lot of different things. Okay. Medications commonly given to folks with low back pain. And the possible side effects. So you got non-steroidal anti-inflammatories. So there are no short-term effects on activity, but may slow muscle regeneration. Long-term effects include GI discomfort, renal dysfunction, elevated risk of heart attacks and stroke. Non-opioid analgesics, none. Topical capsicum plasters, none. Muscle relaxants, dizziness, drowsiness. Selective serotonin reuptake inhibitors, SSRIs. If you look them up, usually you can just look up SSRIs, kind of like NSAIDs for steroidal anti-inflammatory drugs. Mild dizziness, mild drowsiness. So exercise recommendations. So resistance training, focus on abdominal and lumbar strength using 1 to 4 sets, 8 to 12 reps at low to moderate intensity initially. Include flexibility training targeting trunk, hip musculature using minimum 3 sets for 10 seconds. Aerobic training should start with short bouts of up to 30 minutes per day, 3 times per week, progressing to 150 to 300 minutes of moderate to vigorous, and terminate exercise if results in increased low back pain. That's the big thing is and again, the client, there's you got to trust them on what they're saying, right? Are they getting, especially like, is their back pain, does it cause sharp pains and things like that? So like, again, they may start to feel some soreness in their back, right? And again, that could be good soreness from musculature, that could be you know bad pain as well, and they need to be able to recognize which is which, and educating them on that. And again, these are like just kind of some generalized, and really this is really generalized for somebody that doesn't have anything super serious, right? So again, with the back pain, they've got to be basically looked at by a doc, signed off by a doc, saying they can go do these things, right? And again, you've got to figure out what makes their back feel strong, or you think about the whole core again. Like, we want to do abdominal things as well to help with all the musculature to hold them upright, and to strengthen that area, and keep undue necessary pressure in certain areas, and pulling and pushing in certain areas. Um, but it's as tolerated. It's with the thought process, we're trying to, make them feel better. Again, this isn't a like trying to get the low back looking like freaking like Arnold Schwarzenegger low back or anything like that, right? Or their abs and all that. And so again, you've got to approach cautiously, because the problem with the low back thing is sometimes, like I said, you don't know how serious it could be, even if the doctor signs off. Like they said, sometimes they don't know how serious, right? If they do an x-ray and they're like, well, don't see anything on the x-ray, doesn't mean that there might not be something majorly wrong there either, right? And so again, always, anybody that has low back pain, approach with caution, start strengthening and stuff, and, and check on them, right? So after you go through a set, or like each set, each like, or each like each set of reps, at the end of the day, check on them before they come in the next time. Like, how'd you feel, like afterwards? How'd you feel the next day? So, like, kind of get a sense and a guide for what you want to do going forward, right? um, Postural conditions. Posture is alignment of the head, neck, trunk, limbs, and space. Good posture is defined as optimal alignment that allows efficient movement of the body without undue stress on musculoskeletal or nervous system. Postural assessment should be conducted in a variety of static dynamic conditions. Um, Again, we'll look at some different postural conditions. So on 3.2, spine has natural curvature. So we have the lordotic and kyphotic curvature, okay? Too much anterior posterior curvature is referred to as hyperlordosis or hyperkyphosis, depending on the nature of the curvature. And scoliosis is excessive medial lateral curvature. Again, scoliosis is not really one that we can really help with. Maybe in, like, if you have really young clients, because everything's still growing and changing. I haven't seen really good data on people having a lot of success with having an influence on it, but I've heard some folks talk about possibility of it. So, or they've worked with some young folks and seen it improve. And so, again, you got to get them young enough, but usually in adults, not much you're going to do, right? And especially if you look at the one on this, but that's extreme scoliosis. So, okay, we got the normal, right? So keep referring back. So hyperlordotic, and again, depending on the book, sometimes, like you'll hear, like hyperlordotic referred to as sway back, which, depending on, some things say sway back is different than that. Some things have it as, no, that's what it is. It's, again, that's sway back's not a real technical term. So, these are more technical terms to look at. Because you can have hyperlordotic and hyperkyphotic. You can have hyperlordotic only. You could have kyphotic only. You could have, again, you can have a kyphotic back like that, and in the lower part, it can be very flat. So you can have a lot of different combinations. And again, if you look at the scoliotic back, sometimes it's very slight. Sometimes it's very pronounced, like it is in that picture. Okay. Hyperkyphosis possible causes include osteoarthritis, porosis, or thoracic spine injury. When severe, can result in nerve impingement, pain, and impaired lung functions. Hyperlordosis cause includes cerebral palsy, muscular dystrophy, obesity, osteoarthritis. Sometimes pregnancy will cause it. Again, if you think about it, like lower abdominal, so like if you think obesity or pregnancy, again, they're not the same thing, but you got increased weight pulling from the front, it can pull that spine that direction too. And again, sometimes the what it does is you're going to get anterior pelvic tilt with that, and all of a sudden, you've got that where like kind of your booty is more pronounced and you've got that lower back rounding, so to speak. And again, increases risk of injury to lumbar structures, often causes your low back pain. Okay. Scoliosis causes are often idiopathic, but include structural causes from deformity to vertebrae. For example, functional origins caused by muscular issues or anatomical abnormalities such as leg length disparities. If one person's got a longer leg than the other. Again, somebody may just like hip hike out of just normal comfort too much, things like that as they're developing. Causes impaired respiratory function, pain, reduced physical function, and movement capabilities. A lot of times with severe scoliosis, they're very careful about the things that they allow them to do physically, because of the possible injuries and issues that can result in that, in them doing certain movement patterns or playing sports and things like that. Again, exercise recommendations are in table 3.2. Again, fairly general due to the variety of specific conditions and causes, but include a mixture of strength and flexibility exercise to address underlying deficits. For example, training to reduce hyperlordosis includes increased hip flexor erector spini flexibility, strengthening the abs, glutes, and hammies. Let's go back. The thing that, again, like if you go to 3.2, just you almost look at it like a grocery list of things that you don't necessarily have to do them all, but you got to pick and choose, right? And again, depending on the person you're working with, certain things may be easier for them to do, harder. Some things may cause them pain. Some things may actually like make them feel better, and that's what you do. You don't, don't be stuck on doing. And again, also don't get in a groove of, once you like, okay, you figured it out and you're doing that for a few weeks, and again, you can start, like increasing the weights or reps or whatever. It's not a bad idea at different times to start trying to reintroduce some of the ones you tried, or be creative. If you notice, like, okay, well, they can, like, we're only doing 2 movements in this direction, and I feel like if we could just do a few more, we'd see more results. But these other exercises that kind of do that movement cause them pain. Well, look at what you're doing that's working well, and you can kind of, like, create certain movements that may help, especially if you're doing some body weight or you're using, some of the cable crossover machines and things like that. You can get a bit creative, and add little other slight movements, so for example, sometimes, they feel like, well, kind of like if I twist a little bit when I do this, I'm really, like, I feel like this stretch, or I do that. Well, okay, that may not necessarily be a technical movement that we normally use, but if it's helping to strengthen them, some muscles, or stretch some muscles, create a movement pattern that works for them, right? As long as it's not causing any like trauma or new issues or something like that, and you're like, you know what, go with it, right? That's how a lot of exercises are born. Okay. Osteoporosis, defined by the World Health Organization as a bone mineral density of 2.5 standard deviation or more below the young normal adult scale. Okay. We see this a lot more in women than men, especially as they age. But again, even in general, there are some young females that have onset of osteoporosis because they have such low bone mineral density. And it's an imbalance of bone remodeling where there's more bone reabsorption than formation. Okay. So here's a picture of the spongy and compact bones, trabecular and all that. Anyways, so primary osteoporosis, 2 types occur due to age and is much more likely in females, 8-1, than males. So type 1 osteoporosis. Postmenopausal osteoporosis occurs from ages 50 to 65 due to the decline of estrogen production, resulting in loss of 5 to 10% of cortical and 20 to 30% of trabecular bone over a 4 to 10-year period. Type 2 occurs after age 70 until the end of life and is a slower loss of bone, 20 to 25% loss of both bone types. Okay. Again, affects more women than men, but we still do see osteoporosis in men, especially now that we have strange diet culture stuff going on where people don't get enough, we don't get enough exercise in general, which is, exercise is always good for bones, but 2, a lot of people stay away from like milk and a lot of other things that have good levels of calcium, vitamin D, magnesium, and so on and so forth, due to hearsay and whatever garbage they hear or about that. Anyways, yeah, so we've seen increases in years with that. Secondary osteoporosis, also called type 3, is initiated by presence of other diseases such as cystic fibrosis, anorexia, and the use of various medications. So again, some medications may not help, or they may decrease your ability to reform bones and things like that, or they hit you before that with the ability to absorb, the right amount of minerals and so on and so forth. Besides the increased risk of bone fractures and postural concerns such as thoracic kyphosis, osteoporosis is linked to higher morbidity and mortality rates as well. Okay. Common medications. So hormone therapy, previously the most common medication, but it's possible linked to increased breast cancer, blood clots, strokes have caused reevaluation of its usefulness. Cardiovascular and breast cancer risk factors should be evaluated prior to use. Selective estrogen receptor modulators reduce bone reabsorption but can cause GI distress. Exercise, moderate to high intense weight bearing exercises, both aerobic and anaerobic, is most beneficial, although lower intensity exercise may be recommended for those with more fragile bones, right? Again, we're not going to have grandma and grandpa who might be osteoporotic doing like heavy deadlifts, squats, and doing like drop jumps or something with fragile bones, right? Again, those are all good things for your bones, but you've got to have a certain amount of bone health to do those things. Okay. Again, resistance training results in an increase in bone mass, muscle strength, the latter of which can improve balance and proprioception, thus reducing the incidence of falls and fractures. So here's the thing. When it comes to the exercise programming, especially when if you're looking at older adults with it, you got to look at, like safety, risk versus reward. So what's the safest, right? So again, yes, would we like to see them doing squatting? Would we like to see them doing, some of those type of things? We'd like to see that. And just because they can't do it at first doesn't mean at some point you work with somebody long enough that they won't always be able to do it. Maybe not, right? But you got to think in terms of what's best for them, right? So one of my favorite exercise machines, if your gym has it, we don't have it here at this campus, is a standing calf raise machine. Now, the reason I like that, one, anybody that's ever used it, especially young, healthy men and women, and you guys will see, like, you'll load up weights, right? Everybody loads that thing, right? It's one of those things like, my last school I worked at, in the gym, we had one, and I could put all the 45-pound plates on both sides of it, right? It's I don't know how many you could load up on there, like thing you put like 6 on each side or 8 on each side. I don't know what it was, right? Not saying I don't have like huge legs, so don't think like, oh man, this dude must say no. Strong calves, but they're not huge or anything like that. And I could sit there and do like 20, 30 reps like that. Okay. Now, here's the thing. Most people's calves are fairly strong, and when you're in a standing position like that, it's compressed, really good at compressing the spine. Okay. And that's the key. So thing is you can find and again, even with older adults, you can find kind of a heavier weight, especially on that, like if you think of that versus them doing like something else where they have pressure on their shoulders and they're trying to bend at the knees and the hips and things like that, they can't do as much, right? It puts you in a compromised position. Well, this one, you're standing up, you're staying in a standing position, which most people can hold a bit more weight when they're in their standing position than when they're like in a half squat or a low squat, right? That's usually where you get in your trouble spots. So you can load that up, and again, they can just sit there and kind of bounce and do the calf raise. Now, here's the thing. If you have somebody that's osteoporotic, you can do that machine every single time. And it's not about like trying to get them to have yoked calves, but it's just a bone. Basically, you're doing it for bone. It's a good exercise for the bones, right? And if their bones get stronger and stronger and stronger, you can start adding some more complex movement stuff, or as they become more mobile, they're less risk of breaking things or falling and stuff like that. And again, with that, it's kind of nice too, because as they get stronger, you can start loading a lot of weight, right? And that way it's having that effect on the bones. Okay. And so again, if you have one, it's a great exercise, or it's a great exercise to do with folks trying to work on bone mineral density. If you don't have one and you have a gym and you're looking for new equipment, the standing calf raise, again, you can do it with the barbell and things like that. I like the ones where it just has the pads on the shoulders. in general, especially with working with these type of clients, because there's a lot more stability there. They're not, they don't have to work on their balance near as much, less chance of them falling or hurting themselves again. um, I like the barbell one. I do that one. But again, I'm doing that more for my calf health, not really my bone. Again, balance and proprioception, is not an issue for me at my age and in my exercise level and so on and so forth. You got to take that in consideration when choosing the exercise, right? Um, Again, screening should include eval of previous fractures that limit their exercises, muscle weaknesses, imbalances, balance or coordination issues, other disease states, medications currently taken, and severity of the osteoporosis, right? Like everybody's individualized. And again, if they have muscle weakness and like you're thinking, okay, I want to do work on their spine and their bone and mineral density and all that. And if I do these muscles, well, shoot, I can't really hit the quads and I can't hit the hammies because they're gonna, they're gonna have an issue with doing squats. Okay, we'll do two different things, right? So again, you could do the standing leg press type stuff, or not leg press. Excuse me, the standing calf, calf press. Or calf extensions. You hear, I hear called both. It's really it's really you're doing plantar flexion, so it's not really extension, but whatever. But calf raises is really the best name for it. So you can do the standing calf raise, but then you could use other machines like, yeah, and again, you can isolate more the muscles and stuff if you need to like do some leg extension for the quads. So if you want to get the quads at the knee, you want to do some hip, like do some like kind of hip marching raise, or you can strap them into something where they do some hip flexion type movement again to get the other side, right? I mean, if you have to do that, right? On the backside, if you're doing you can do hamstring curls, or you can do, you can do kickbacks, that get the upper part of the hamstring as well as the glutes. I mean, like, you got to look at it as, how do we attack this based on the person, right? You can do the multifaceted lifts where you're doing more complex movements like squats or squat to press or whatever else. That's fine if people can do that. But on the far end of that, you can individualize the movement itself and isolate each joint as you do it if you have to, right? Or if you can do a combination of both, then great. Okay. And again, always get medical clearance and implement precautions to prevent falls. For mild to moderate osteoporosis, weight bearing activities like walking or running 3 to 5 days a week at 55% to up to 75%. Maximum heart rate for 30, 60 minutes per session is recommended. I know it's a mouthful. Light intensity, low or no impact exercises such as walking and swimming are recommended for those with severe osteoporosis. Again, swimming is going to help with the osteoporosis. So if you got them, walking will help some, swimming will help zero, because you're in low gravity environment. Actually, it's one of those things, like in competitive swimmers, because of the amount of time they spend in the pool. They have shown studies where the folks that just do swimming all the time, but they don't do a lot of other weight bearing stuff, are at a greater risk for osteoporosis, actually. And so, again, if they're swimming for muscle strength and for some of the other benefits with that, cardiovascular, whatever, definitely got to do some type of more intense weight bearing type of things to counterbalance that, or to just add to the fact that we're trying to battle the osteoporosis, right? Because the osteoporosis may prevent them from doing a lot of the, or getting the exercise they want. So the swimming is great, but at the same time, we need to do something to combat the osteoporosis. um, 2-3 days a week of resistance training using 2 to 3 sets, 8 to 10 reps at 60 to 80% 1 rep max. Again, another mouthful. Monitoring balance demands with lower intensity depending on severity. Flexibility training 5 to 7 days. And you can always work on flexibility every day. I mean, it's a good way to kind of round out workouts because your body's warm. All the muscles are warm and ready to go at the end. especially hip, knee, pectoral girdle. 15 to 30-second stretches, excessive twisting or flexion of spine should be minimized. Again, those oblique trainer machines that they have where you twist the spine. You got to be real careful with those, especially people that have osteoporosis. Older folks in general probably don't really need to use those, although they typically are the majority of folks that like to get on those because they tend to be in the machine areas of the gym. And so, they'll work their way through all the machines. One thing that you'll notice when people do that, they like to lean into it. So they're not actually turning the spine in a healthy manner. A lot of times they're doing like kind of a swinging motion instead of a twisting, which can cause some other issues as well. So I'm not a big fan of those machines because if I want somebody to twist and things like that, I'd rather them, like be under supervision and learn how to do something correctly. Where a lot of times people feel like the machines are just safe. So they, they'll get on them. They don't realize like you still have to be in control of yourself when you do the machines, right? Osteopenia, defined as bone mineral density of 1 to 2.5 standard deviations below young normal, and presents an increased risk for osteoporosis. May be present in younger women as a result of anorexia, poor nutrition, amenorrhea. Interventions made soon after diagnosis can reverse or slow progression to osteoporosis. Again, young girls, you'd be surprised how many young and like young, healthy looking girls will have osteopenia. They basically just low bone mineral density. Effects of exercise and recommendations are similar to those for osteoporosis, but with fewer precautions against high impact activities. Osteoarthritis, degenerative disease that causes pain, swelling, decreased range of motion, affected joints with knees, hips, hands, spine are the more frequent areas. Females are more likely to have osteoarthritis than males, with risk increasing after age 50. Causes largely unknown, but include joint trauma, excessive body mass, structural misalignments, and muscle weakness. And there is no cure. Again, exercise and things like that can sometimes make it, or it can sometimes help. It won't cure it. Sometimes it makes it worse. And sometimes there's times where it's, like they'll go through, like sometimes things are feeling good, and then like it's a mess. Medications for osteoarthritis used primarily for symptoms and include NSAIDs, non-opioid analgesics, glucosamine, chondroitin supplements, topical analgesics. In case you guys ask, glucosamine chondroitin supplements are one of those hit or miss supplements. No good research will really show you that it really works. It doesn't really show you that it doesn't either. You guys got to understand, a lot of times we get things that basically they have, when it shows like there's no significant like results or whatever. Sometimes it's just because with certain supplements, and again, this is looking at the hard data research, and then also looking at case studies and things like that. Like if you get into case studies, there's some folks, they start taking glucosamine chondroitin, man, things feel great. um, some people, they're like, nothing changed. Okay. So all I can tell you with that is if you're dealing with it and you want to try it, it's up to you if you want to spend the money on it and try it. It may work for you and it may not. That the best I can give you with that. Um, there's a lot of different topical analgesics that all kinds of companies, they have stuff where you rub on your joints. I don't know. I know a lot of people are going to the cannabis based oil stuff and rubbing that. I haven't really seen a lot of that research yet on how effective it is. Again, I've heard some folks that swear by it. So other medications to reduce inflammation or attempt to improve joint function include corticosteroids, hyaluronic acid injections, and again, it's kind of hit or miss with people on those. Effects of exercise. Exercise may result in joint pain reduction, improve joint stability, counteract muscle weakness. Again, sometimes the exercise may cause you more joint. It's really individuals, right? You got to take it as it is. Aerobic exercise with large muscle mass, including swimming, cycling, walking 3 to 5 days per week at light to moderate intensity for 20 to 30 minutes. Recommended resistance training 2 to 3 times per week at moderate intensity, and flexibility exercises 3 or more times a week with 5 to 30-second stretch periods, 3 sets of 1 to 5 exercises. Joint sprains and dislocations. Joint sprain is damage to a ligament, is among the most common joint disorders, most likely to occur at the ankle, knee, or wrist. Ankles are, sprained ankles is most common thing that you'll deal with if, as a strength coach or a athletic trainer if you go those realms in sports. Again, they can be anything from like kind of a nothing injury to a major injury. Again, when you get into the knees and, wrists sometimes can be like just a little like inconvenience. But again, a lot of times by the time somebody jacks their wrist, they a lot of times it happens with a foosh injury, falling on an outstretched hand. Those are usually pretty bad. Knee injuries are usually no bueno. They typically, you rarely have a knee injury where it's like, oh yeah, you're just going to be out for like a few days or a week or so on. Usually they're kind of major. Lateral ankle sprains are the most common in basketball, football, soccer, volley. I've seen them in volleyball. I've seen them. I think I saw a dude doing golf one time. Just kind of over rotating when he's swinging. You see people walk and they'll step on a uneven surface and do that. Joint dislocations occur when the joint surfaces are separated, resulting in pain, limited range of motion, numbness, and tingling. Shoulder is the most common dislocated joint. 71.8% of all dislocations. I fall in that group. I've dislocated my shoulder several times. I've had to have 3 surgeries to correct the pain and issues I've had in my shoulder. Long story short, my shoulder now feels great after my 3rd surgery. Limited range of motion, but I can pretty much do most anything that I was doing before. I can't hold a normal bar on my back to do squats, so I got to use the safety bar, but that's really about it when it comes to the range of motion and the issues that I have. So yeah, is what it is. So grade 1, minimal stretch with no tearing and no instability on sprains. Grade 2 is moderate stretch, some tearing of fibers, some instability, and grade 3 is a complete tear of ligament with resulting instability. Dislocation usually caused by an impact or falling, degree of separation, partial or complete, extent of associated injury, simple means no bone trauma, complex, notable trauma to the bone and ligaments, or severe additional damage to blood vessels or nerves. Mine was a complex. I don't believe it was severe. I don't think I had issues with the blood vessels or nerves. Got pinched nerves in it, but I don't think it didn't cause any permanent damage. So medications for joint sprains, dislocations, NSAIDs, non-opioid analgesics. Caution is recommended against long-term use of those. Effects of exercise for grade 1 sprains. Weight-bearing exercise after initial swelling has disappeared is allowed to improve mobility strength. Grade 2, 3 will require a period of immobilization, treatment by a PT. Then they'll be released, and you more likely you're still going to be doing like kind of post-rehab PT stuff with them. Recommendations are all summarized in 3.5 for both the dislocation sprains. Again, rest for a week, then work on restoring flexibility strength for 1 to 2 weeks with low to moderate. This is basically like like once they're released, or it was just, like a grade 1 sprain or whatever, right? Body weight exercises 6 to 7 days per week. When the joint is pain-free, final phase of strengthening is completed. Utilize low to moderate joint specific full range of motion exercise 6 to 7 days per week. Moderate resistance can be added 3 times per week. Just to give you kind of a realistic view of what happens, everything from a grade 1 sprain, which I've had several of those in the ankles, to grade 2, grade 3. I've had few grade 2s and I one grade 3, plus the dislocation in multiple areas. Anyways, so just those of you that have never gone through any of these, if you're working with somebody, just to understand, even after grade 1, especially like at the ankle, it's never going to feel quite stable. and even a year, it can be like a year or years after like some of these injuries, that joint may not ever feel stable. Now, you do strengthening, you do stability, you do all that. Sometimes they will get where just one day they forget they had the injury and they feel stable and they trust the joint again. Sometimes it's one of those things they'll always be cautious. It is what it is. Depending on how bad it was and how long it took for stability to come back and so on and so forth. Yeah. Joint replacement surgery involves replacing the damaged joint with synthetic prosthesis in order to improve function and eliminate pain. Osteoarthritis is a principal cause of hip and knee replacement surgeries. Again, we've seen these in sports. Bo Jackson had to have a hip replacement because of actually the medical doctors missed the fact that the blood supply to the head of his femur was severed during his injury. And if they would have caught it, may have saved his hip. But anyways, that's a whole different discussion we'll have. Effects of exercise. Physical activity is recommended to stimulate blood flow, reduce incidence of blood clots, which occurs in 40-60% of joint replacements. Again, recommendations: allow a return to stable pain-free movement under supervision of PT before they get to start working with you in resistance training. Begin with low impact, simple aerobic exercises such as walking, cycling. After 6 months, moderate to vigorous exercises can be phased in on individual basis, depending on what they're dealing with. Frailty occurs in older adults from combination of poor health, reduced muscle strength, reduced ability to engage in physical activity or activities of daily living. Again, the more you sit around and do a whole lot of nothing and you get used to that, it has other effects as you get older as well, right? You see some old folks that are like, and they don't ever get frail. And then you get, a lot of old folks are frail. And most old folks are frail because, again, they don't do as much as they should, right? So 20-50% of individuals age 85 years or older are likely to experience frailty. Result of age-related decrease in functionality of organ systems exacerbated by nutrition, environmental factors, and coexisting diseases, and lifestyle, right? Lifestyle is a big one in there. Medications will vary wildly. It's important to be knowledgeable of the effects, side effects. And again, you're not always going to know every medication somebody's on. Great thing is you can always look them up and they'll tell you everything, like you can always find, like WebMD to like there's different like RX apps and things that you can even have on your phone where you just start typing and all of a sudden the medication will like pop in before you even done. You're like, oh yeah, that's what I'm looking for. And it'll give you the whole breakdown, like what it is, what it does, things to look out for, some of the side effects, so on and so forth, right? Sure, proper screening prior to activity identifies existing disease conditions and associated medications. Effects of exercise: increase functional capacity, increase neuromuscular coordination, improve balance, reduce their risk of falls, increase their muscle strength, power, and mass to reduce risk of falling. Again, power, be careful with, especially with older. There's power things you can do. You just, be wise in adding power to it, right? Improve cardio function to attenuate cardiovascular disease and other comorbidities. Ensure medical supervision of any fitness testing or exercise as recommended. Aerobic training, again, start light. Everything with in older group, you always start light and kind of see what they can do, right? And just progress them as they go, right? And you'd be amazed at how far some people will progress to. Again, 5 minutes per session, up to 3 times per day, including large muscle activities such as walking, cycling, swimming, chair exercises. Again, resistance, progress from light to moderate, 3 days a week. Include neuromuscular flexibility training on most or all days of the week to improve coordination and balance, and address nutritional deficiencies with referral to nutritionists and watch for symptoms of dehydration. Sarcopenia is a gradual loss of muscle mass and strength as a result of age. It's going to happen. Unless you're going to roid up as you get older, it's just going to happen. Now, again, if you're exercising, doing everything you should, it happens at a much slower rate. Okay. Contributing factors include inactivity, poor nutrition, chronic disease, lower anaerobic hormone levels, decreased muscle protein synthesis, and spontaneous muscle denervation. Medications addressing nutritional deficiencies, administration of testosterone or other androgenic substances, although there are common side effects with testosterone supplementation, including fluid retention, orthostatic hypotension, and carpal tunnel syndrome. Exercise resistance training generally reverses or slows. Again, why would it do one or the other? Reverses would happen in those who are very deconditioned and haven't been doing what they should have been doing. It will slow in those who are like keeping up a good regimen, and they always have, right? With notable exceptions of neuromuscular remodeling from spontaneous denervation of type 2 muscle fibers, resistance training should focus on type 2 fibers, right? So go big or go home kind of thought process. Not that you're trying to yoke people out, but that's the type of lifting they need to be doing. With advancing age, pre-existing conditions should be considered. Appropriate modifications, precautions undertaken when addressing sarcopenia. Avoid high-intensity testing like 1 rep max in these folks. Again, don't do 1 rep max with those with the osteoporosis either. Resistance training should be done 2 to 3 times per week using 1 to 3 sets, 10 to 15 reps at light to moderate. When they start, again, you can increase as they go. Aerobic exercise 3 to 5 days a week, 20, 60 minutes per session. Light to moderate intensity and flexibility and neuromuscular training can be done daily, right? You'll see a pattern. All these are very similar. Okay. All right, guys, that's it for chapter 3. If you guys have any questions, just let me know. We'll do live lectures as well. So we'll do chapter 4 next.